Well, good afternoon, ladies and gentlemen, and a warm welcome to Professor Thinus Kruger, who, as you know, is the founder of the Avitas Fertility Clinic, which is a satellite of the University of Stellenbosch. And this is a private practice facility at the Vincent Pallotti Hospital. Professor Kruger is going to be speaking today about male factor, azoospermia, and other aspects, including varicocele. We've had a great call from many of our listeners and delegates to speak a bit about male fertility because we do tend to concentrate on female fertility, which is not surprising since we're gynecologists. But we have a wonderful facilitator over here in our midst in Professor Thinus Kruger. He began this in 2003, the Avitas Fertility Clinic, and it's been going strong ever since. Male fertility, as we heard previously, recently, we had this wonderful presentation by Professor Kruger, is a very, very important part of conception, as you would imagine. I'd also like to thank Chris, our person with the technical expertise for facilitating everything. And of course, our co-host of the Pelvic Floor Foundation of South Africa is Professor Steve Jeffrey. He's the co-host. And good afternoon to you, Professor.
Good afternoon.
Good afternoon, Professor Steve Jeffrey. Just to remind you all, Steve and I are doing many presentations at SASOG, which is next week. I'm hoping as many people as possible can come to the SASOG meeting, Congress, starting Wednesday evening with a presentation by Professor Sue Forkus and then Olivia Bagiri. And then we're going to go on to the Congress, which is the Thursday, Friday, and Saturday. It's wonderful to have so many people, a wonderful program, and it's going to be a splendid Congress. So without further waste of time, I present to you the male factor, azoospermia, and other aspects of male infertility. Thank you, Professor Kruger.
Thank you, Peter and Stephen. I told you already, I appreciate the invitation. So we'll dive in. This azoospermia problem is not so common, but it is something that we all encounter. And if you run into this type of case, you want to try to make a correct diagnosis. So if you, with first consultation, find azoospermia, it is very important to repeat the semen analysis. Wait about 4 to 6 weeks. It's preferred to use a unit, one of the IVF units in the country, because they are very accustomed to work with sperm and will tell the patient to have abstinence for about 2 to 3 days, but up to 7 days is fine. And then if they don't find sperm, they will centrifuge to find rare sperm in the background. And of course, that is very important. Just to think about azoospermia, I've got 2 blocks there, the obstructive type, and we just focus there. Obvious vasectomy or congenital absence of the vas, cystic fibrosis, most common reason. Then conditions of the epididymal or ejaculatory duct obstruction, usually infection, even TB here in South Africa can be a cause. And on the other side, the non-obstructive group will be a testicular failure for some other reason. Common is the mumps that the child would have contracted at 12, 13, 15, 17 years of age. Klinefelter's is a condition. Then Y microdeletions, which we will talk about. Chemotherapy, radiotherapy, central lesions and reasons can be a cause, like a hypo in a young child will cause them not to go into puberty and can be treated, and one can even reach a stage where you can freeze sperm. So the history, we start with the history when you see a patient with azoospermia. And it is important to look at the development of that person, previous fertility, childhood surgery, all obvious things, genital infection, significant testicular trauma, chemotherapy, and very, very important, the misuse of testosterone and anabolic steroids. I've heard recently that up to 4% of young rugby players at school are now exposed to anabolic steroids. Of course, they are tested, but still this type of thing can go on, and that will affect their reproductive potential a lot, especially if they use it chronically. On examination, you look at the test.
Sorry,
Yes,
on that, can I
yes,
just ask a question on this
yes,
business about, I know it's pretty ubiquitous and widespread, the use, and shall we say the abuse
yeah,
of male, is it testosterone and other anabolic steroids in
yes,
rugby players? Is this school
yes.
rate, say 4% in schoolboys?
Yeah, I've read that. It's very, very well known. If you look at the some of the children, you know, if a patient comes into your office and he looks like that Rocky guy, you know, you must
Sylvester Stallone, Rocky guy. That Sylvester
yes,
Stallone, yeah.
Salone, you must really immediately think about anabolic steroids, but it's part of your routine history and you will pick it up. But they often do not disclose, so you must probe a little bit, and there are certain gyms that will supply steroids. Some patients do not even know that they're on that type of supplement. They get it illegally through gyms. Certain people.
So if a person has been using it, say as an when they play rugby and they get from their rugby coach, and they
Mm,
stop it, how long
mm.
before they reverse, or is that damage?
No,
So
you can if they've used it for a year or so, it takes 6 months, 9 months, a year to reverse it, sometimes quicker. If they I had a cage fighter recently who
oh, that's
used
oh
it.
Chris, he's a cage fighter.
But I don't know if it was allowed, but this cage fighter used it. He used it for many years, and we couldn't get it back. We did in the end treated him for 6 months with gonadotropins. The microTC showed a few sperm, and those sperm were very misshapen and did not get the eggs fertilized. So we had a zero fertilization.
Yeah, last time I don't know if you remember, you told us last time that cage fighters tend to have sperms with broken necks. And I can quite understand because if you've ever seen a cage fight, it's a very violent thing, and I can understand it that it breaks the sperm's necks. But
Yeah.
sorry, I interrupted. Thanks. Please continue.
No, thank you. I think it's a very important interruption. It helps us to just emphasize a very important point. Thank you. So when you examine, you look at the testicular volume, the consistency of the testes. You look at the vas, if you can feel it, and examine the epididymis, and you feel for varicocele. And I'll talk a little bit about the varicocele. If you do not examine the male, I think we've covered that also last time, then send the person for a good urological examination to your urologist. Investigations help you to refine the diagnosis after you've done what I've just mentioned: FSH, LH, total testosterone. Also prolactin. It's rare that you get hyperprolactinemia, but it's possible. Look at the thyroid TSH, but FSH, LH, testosterone, most important. You look at the semen volume and the pellet afterwards to evaluate sperm, and then you do genetic testing, targeted genetic testing, which I'm going to talk a little bit about. So this is about the semen volume for a second. If the volume is very small, we talked about the semen analysis last time, and there's no volume of only a few drops, it's possibly retrograde ejaculation. You ask the patient at another time to come back. You ask him to urinate in a cup before ejaculation, and then after ejaculation, urinate again, and the lab will evaluate the semen, if there's semen or urine, spin it down, find the sperm. If you find sperm, one can later on use citrus soda in a test phase, get the pH correct in the bladder, and then the ejaculation and retrieve the sperm. And IUI can be very successful in these men. Let's look at the hormone story. If you do FSH and the FSH is high, it suggests, of course, impaired spermatogenesis. If it's very low, like 0.1 or 1, it suggests hypogonadotrophic hypogonadism. So that's a central cause for azoospermia, but one must also exclude, for example, a brain tumor, a hematoma, or something like that. And then normal FSH can occur in obstructive and in non-obstructive azoospermia. So it's a guideline. It helps you a little bit. Now, we always ask for chromosomes and then ask for the Y chromosome testing to map the A, B, and C regions. Just focus on the right-hand side. I just want my cursor there. If this is gone, the A region, and that is where the gene for spermatogenesis, there will be no sperm. B, and I'll show the slide again, to do with maturation arrest, and the C region, if that is intact, there should be sperm. So in cases with azoospermia, non-obstructive or very, very severe oligozoospermia, one can look at these regions in the Y chromosome. I'm repeating what I've said. So if there's a deletion of this area, and you get that in the report, it's usually a certainly only cell pattern, and very, very rarely will you find sperm. So microtasia is not recommended. The B region is in between C. If C is gone and A and B, for example, is left, the chance for sperm is very, very good. So on the right-hand side, I'm making the point again, do not offer a microtasia. Testis biopsy will not help. So they need microtasia because there's very few sperm, and the trained urologist will find tubuli dilated. And if there's a total deletion of the A region, you do not offer microtasia. Consider it in non-obstructive azoospermia, where there's no chromosomal defect, when there was a failed TSA. Klinefelter syndrome can be successful, but only with microtasia. And then if there's a AZFC deletion, your A and B sections are left, and spermatogenesis is possible, and for those you offer it. Chemotherapy, there are selected men where you can offer microtasia in spite of chemotherapy. So just a word on the microtasia. It's a targeted microsurgery. It searches for um, um, tubuli that's dilated, and the urologist trained will see these tubuli, and he will cut little pieces from the tubuli, give it to our scientist, and then if there's sperm in there, they will find the sperm, and of course, one can offer ICSI. It's important just to say a word on that. We synchronize the females by freezing oocytes beforehand. If we find sperm, sometimes we just find 10, 15, 20 sperm, we can then thaw the eggs and fertilize with ICSI. But if you try to synchronize with fresh and you want to freeze these very severe malfactor cases, the freezing is not successful, the freezing of sperm. So that synchronization and pre-freezing of oocyte, very important. So point 3 there is you require, of course, a microscope, embryology support, and the surgeon works under a microscope. And here in Cape Town, we have 2, and they've been trained in the United States after Dr. Zarabi, who was the first person that was successful, but sadly now in overseas, working in another country. But we get a fantastic results with these 2 urologists. Now, Peter, I wonder if I stop here for a second. We're going to talk about the varicocele and then 2 other points, and then we're done. Perhaps there are questions now while
we do. Professor, I've got one question person. It says, a practical point, what is the best way to collect for a man, a patient man, to collect sperm prior to these tests and prior to interventions? In other words, I think what he means is, does it collect it at home? Does it collect it at the laboratory? Does it collect it at a Vitas? Where must and how must it be? It's a practical question. How and where must it be collected? The sperm.
Yes. Can collect it at home in a sterile container. So you must have the correct container and bring it in. Must be at the clinic within 1 hour. You're in Cape Town? Yeah, 1 hour. Because we put the sperm on a bench and it sits there in a just a normal temperature incubator 45 minutes. So while he's driving, and he must put the sperm in his pocket, not in a cool or hot bag, then by the time he's at the lab, it's liquefied. So it
Does
is
it have
possible.
to be in saline, or is it can just be dry?
No, it's just ejaculate straight into a dry container, a sterile
plastic or
dry
glass?
container. It doesn't matter, but most of the time it is a non-toxic plastic container.
Okay, thank you. So it doesn't matter. If it's collected in the laboratory, do you, for example, at your Vincent Pallotti facility, do you have a person there that collects it, or must they bring it in from home?
No, we have special, what we call masturbation rooms. Peter, I can invite you even have a special girl overseeing this process. So, but that's just a little joke. So, no.
I see. It's a joke. I'll tell you why, Professor Kruger. I remember when I worked in the, we also had one at Kruger Hospital. I don't know if it's still there, masturbatorium. And what really intrigued me is that they had a couple of chairs and a low table there, and on the table were Farmers Weeklies. And I thought to myself, gee whiz, man, how does this work? But that's also, as you say, by the by.
Yeah, but you know, there are pathology labs where it's really a toilet that they must go to, and that is unacceptable. So we have really a well-equipped room, clean, neat, and private.
Private,
yeah. But there are certain men, and I can understand that would prefer to give the first sample at home, and we put their minds at ease, they can bring it in.
Okay, thank you.
Was that the whole question?
Well, that was, yeah. He wanted this. He wanted the nuts and bolts because, when we ask for, we're doing a workup, and
Yes.
we hand a little specimen, a little plastic thing to the male. He says, "Well, what do I do with this? And
Yeah.
how long have I got? And where does it? The sort of actual factual nuts and bolts of how
Yeah.
to collect a specimen. How long has he got? Where does he dad? But must it be with saline or can it be dry? That
Yeah.
sort of question that you've answered. Thank you.
Yeah. And also, we had cases where they put it in different and in unsuitable containers. Um,
Such
and
as?
of course, like a bottle that you see there was Vaseline in, I mean, it must be a sterile, at least a urine cup from
Yeah.
the pathologist, at least that. And then I think what you're asking very important because it's not easy for the men, and you adapt to what he wants and make it easy. I
Yeah.
also think I'm saying again, a toilet somewhere in a building is really not right. And then I say, give it at home, bring it in, and we will get good result.
Okay, thank you.
So, Kenneth, just ask you a question about this. It's quite specialized testicular biopsying. How readily available is that expertise by the urologists? Sounds like there is at least one person in Cape Town. But
Two,
what
there
about
are two,
other
two,
centers? Okay,
two
two in
in
Cape
Cape
Town.
Town. I'm not aware, just background. So I think the other centers must tell us it is not something that you just start doing. So these two went to America where Dr. Zarabi went, and they were trained. And it's a tedious process. You must know what you must look for. It's those so-called dilated areas, tubules, and then the lab must be ready to receive. And sometimes they work in the theater, but if the doctor is far away, they will collect and take the tubules in medium and then work at the lab at our clinic.
Okay, thank you.
All right, so we're talking about the varicocele. It is a common surgical procedure. I don't know if people do it for the right reason, so I just want to make a few points. It must be palpable. That type of varicocele, if you repair it, will help the patient to have better motility and higher counts. Even azoospermic men can benefit from repair of a palpable varicocele. It raises the temperature. There's more oxidative stress, more DNA damage, and it may impair spermatogenesis due to the varicocele. So if you repair it, it improves outcomes. And on the right-hand side, that's just a summary. It will increase the concentration, motility. The word selected pregnancy outcomes, the literature is not clear on pregnancy outcome. But from my point of view as an andrologist, gynecologist, I would prefer a good count and an improved count. And the studies are very, very difficult to do when you say endpoint is pregnancy, because there are many female factors affecting outcome. But it's easy to do studies looking at pre-count and after 3 and 6 and 9 months post-operation count. And in those cases, definitely benefiting the semen parameters. So if you look at the right-hand side, the red column there, the red block. Ultrasound detected varicocele, really no literature supporting correction of those. If the semen parameters are normal, must you correct the varicocele? And I think if they battle with infertility, first thing that I do is do a DNA fragmentation test. A tunnel test is one of those tests. And if that is affected, I think that the male can benefit from repairing the palpable varicocele. And then again, the ultrasound finding alone is not enough. So when you feel it, the green block, the couple is attempting conception. Of course, that is important. If a varicocele is not bothering a male and the family is completed, then you don't need to repair it. And then, of course, if there are abnormal semen parameters with the palpable, obvious that you must help the male. I've talked last week, but I just wanted last time about smoking and alcohol intake, marijuana, excessive heat, saunas. One must correct those things and also take a good history on intake of medication. Overweight is a problem, and one must give attention to that because that affects the semen parameters for obvious reason, very high temperature in those overweight men, diabetes and other diseases, medications. So have a holistic view at your patient. And then always when you are working with a male, look at the female because she's contributing a lot and you can't separate the two. Any questions here?
Yes, I've got another question here.
Yes.
It might be from the same chap. In this question, it's a very quick question, do people have to have fasting prior to semen collection? In other words, must they abstain, or is that old news? Do you have to abstain?
It's important. We try to standardize. It's a good question. Standardize the due of the semen evaluation of semen analysis. So we usually say 2 to 3 days abstinence, but just a misconceptions among physicians also is that frequent intercourse, like daily intercourse at the fertile time, will not negatively impact on semen parameters. It actually improves. Motility will improve. But when you do your semen analysis, we standardize and say 2 to 3 days abstinence. On the other hand, if the male, if there's a 10-day abstinence, 14-day abstinence, I have farmers from the Karoo, they think that they handle themselves like they do their bulls and abstain for 2 weeks. Very bad semen parameters, very bad motility, and they must first ejaculate and then 2 days later come and give a sample. But you will find poor parameters in those long abstinence patients.
Okay, so if a person has intimacy every night, it does not negatively affect the pregnancy rate outcomes. It doesn't cause watery sperm.
No, it will improve quality.
Okay, so it's a good idea, not a bad idea.
It's a good idea, except if you have a male with a low count, then we like 5 million per milliliter or less. So he's in the Azoospermia group. There we tell them every second day, just to improve the numbers. But for a male like you, Peter, with 100 million sperm daily is fine.
Okay, thank you very much. I'll tell my wife.
All right, here we are. Last 2 slides. I first want to just reflect back on the semen analysis. And I'm quoting here an article of Dani Botha, and it was published in Fertility and Sterility. And it's just making the point that if you are dealing with a female factor, like endometriosis, then 1 in 3 cases, the data showed it, there will be a male factor. So you have 10 endometriosis cases, 3 of them will have some other form of male factor. And I think it's important to make that point, to tell the general gynecologist dealing with infertility and endometriosis as a reason to not forget the male, because you can compensate for that problem by addressing the male factor. Any question here?
Why is that, Thinus?
It's just facts, because people, us gynecologists, forget. We focus so much on the gynecological problem and correcting the endometriosis, and I get often cases, female well handled, but the male never been evaluated, and then he can have azoospermia. Look there at the 117 cases in this series. That's higher than we expected, but one can have even azoospermia. You can have a lifestyle problem on the male side, and while you are working with the endometriosis, correct the male factor, take a good history of the male, or send him for evaluation, and make sure that you are top notch with the male, and not focusing only on female. Okay.
Okay.
All right. The next slide is very similar. On anovulation, if I'm dealing with someone not ovulating, it's the same thing. 65% of your patients, the male will be good, but there will be approximately the same pattern of single parameter defects, double parameter defects, etc. The serious defects is about 12% in the endometriosis cases and anovulation cases, but they are there. And that's all that I'm doing with this slide. Just tell you that think about the male when you are dealing with the female. Never separate them. Questions?
I'm just got another question over here. If we
Yes.
talking about thinking about the male and sending them for semen analysis, if you send them to a general pathology laboratory, let's say for argument's sake, PathCare, are there people in a general laboratory like PathCare typically that is able to do a good semen analysis? Or do you have to send it to maybe some specialized laboratory that specializes in semen analysis?
Yeah, it will vary from big lab to big lab, but I'm making a general statement. It's easy to count sperm and judge the movement relatively accurate, but the mistake of many of the general labs, they can't read the morphologies. So you will find many men classified with a so-called P pattern, meaning a morphology of 1%, 2%, 3%, and then it's false. They report a false, it's because they are not fully trained. So I will say, if you have a abnormal test from the general lab, before you do anything, send that male after 4 weeks to a clinic in Johannesburg, Pretoria, fertility clinic, and let them repeat the analysis and compare the reports. And if they, I think I've made.
Sounds like jolly good advice.
Yeah. Okay, last slide. So I'm just summarizing. Is that my summary slide? Let me. There's the summary slide. So if you're dealing with azoospermia, you think about obstructive and non-obstructive. By doing a very good history examination and then your special investigations, you will get close to an answer. I wanted to make the point of the AZF results to help us to guide prognosis. I think in today's world, the look at the long arm of the Y chromosome, very, very important. And then you have your microTC, be aware of that. That can help a number of patients with severe male factor infertility. And then I made the point, varicocele, repair it only if it's palpable. And always look at lifestyle on male and female side. Thank you, Peter. That's my story for today. But I'm still available for questions.
Yeah, questions. I'll quickly start the question, then Steve can carry on. Remember last time we spoke about reversal of vasectomy, and he has an attendee that says there's two questions here. The first is for males and females. What is the success rate for a reversal of a vasectomy? You mentioned last time it's better than we thought. Can you just touch on that, and then I'll give you the second question.
Yeah. So if you are dealing, if you reverse, you must look at the age of the female. We made the point last time that the 30-year-old married to someone that had a reversal will be much more successful. So you can go to and say 30-year-old, 50-60% chance of success. But if you are at age 40, I think one must really wonder about reversal. I will not do reversal there, because now they're 40, you reverse, you must wait at least a year to give a reasonable chance for a pregnancy. They qualify for IVF, ICSI, testis biopsy as a first choice. Now, those are the spectrum. And I think if you are dealing with someone 35, you are in between, you can consider a reversal still there because you have time. But the 38, 39, 40-year-old, better to go straight to IVF.
Okay, now on that score, sorry, Steve, I hope I'm not interrupting.
No, not at all.
If a man has a reversal, who does the reversal? And is there a special center for this? Because it sounds like something that's technically very challenging.
Yeah, it's like the fallopian tube. I think, as you know, we understand the tube, fallopian tube, and people skilled in that field will do better than someone doing it now and then. So I think I use the urologists that I know that's focused on infertility, and I know they're doing a lot of reversals. If it's a good urologist, but he doesn't do a lot of microsurgery, then it's not I think actually the urologist must say, listen, I'm not doing this. I'm doing this once a year. Then you refer to someone doing it often. And I use the two guys in our setup here in Cape Town that I know is operating often.
Okay, so the second part of the question is the vice versa. If a woman of 35 comes, she's had a sterilization 5 years ago, she meets a new partner, and she wants a reversal. Is it better for her to have a TL reversal, or should she rather go for a IVF?
No, I think if she's in again, and you will know that, if I can quote Igno Siebert, Igno does a lot of reversals. We've started long ago with the microscope and open reversal. We can do it as effectively laparoscopically. So I think the downside, Peter, is the fact that medical aids do not always cover it. But send the person to someone knowledgeable to do laparoscopic reversal, because that's the way to go today, but one must be skilled. Now one can weigh and say it will cost you I'm guessing when I look at hospital cost, because it's an hour and a half operation, so theatre cost will be a factor. Is that theatre cost not the same as one IVF? You know, so there's not a right and wrong answer here.
Okay.
But it gives the patient freedom if they know that they can perhaps fall pregnant on their own. But there will be a percentage. So the pregnancy rate is 70% for reversal in younger patients, that 35-year-old, where, you know, again, yeah, I think perhaps that's enough said.
Okay, so
Yeah.
I get it. Okay, Steve.
Yeah, Thinus, what I mean, what are the realistic expectations for smoking cessation, weight loss, exercise, etc.? I mean, those are the things we routinely say to patients, but do we have any evidence or strong evidence for any of those?
That the people actually do it, Steve.
Yeah, or you know, what sort of improvements can we expect? I mean, what kind of sort of incentive can we give to patients? You know, or is it just more like generic in a way?
Yeah.
Going to church. Just go to
Let's,
church.
yeah, difficult one. I haven't looked at the literature for this lecture on weight loss, but we know from the PCOS studies that is very solid. That if you remember that we always say lose 7 to 10% of your weight, you will start ovulating, and then you create a chance for pregnancy. So to lose, I think one must not be unrealistic with the patients. They must, but they must do everything that they can to at least lose some weight to try to enhance the ovulation quality and reduce miscarriage rate, because we know about the leptin story and the toxic effect of overweight and a bigger chance of miscarriage.
Okay, thank you.
But I still think, you know, I'm a little bit like a politician now, but at least I have the PCOS work on my side to answer you. But I think we cannot ignore it. So if you, as the physician, is not knowledgeable about advice on weight, and we then use the dietitian, bring in a team of people. There are patients that will need bariatric surgery, but I mean that's the spectrum. But I think centers focusing on weight. I think what your question was also for me, I was immediately thinking about people lose weight and then they gain it again. That story.
Yeah.
But we must do our best to get them in a good shape for pregnancy.
Absolutely, and I think well, certainly in females and women, we're seeing quite significant impacts by the Monjaros and those injections, and yeah, I suppose this is a role for it in men as well. So yeah, and it's a conversation that needs to be had. Veronique's asked a good question about should we then be asking more for DNA fragmentation tests on sperm, and you know, should this is something that should be done by generalists, or should we wait for those patients to be then seen by you guys?
If you there's very few people doing DNA fragmentation. We are sending our slides away to someone in Johannesburg who worked under Dr. At Western Cape, Henkel, and he was very knowledgeable about that. So yes, I think that it's better to find out where can people do the DNA fragmentation test. Not wrong if the person does that before they refer, but also need to send it to the right center. I can help them to get to the right center if they want to email me or whatever.
Okay, thanks for that offer. And then, I mean, we also just all been trying to understand the whole role of GLP-1s you might know this answer, but just Frederick again is asking, are there any impact on the sperm abnormalities
Yeah.
in patients using GLP-1s? Are you aware of anything?
I'm not aware, but I know that in the female, there must be a washout time of 2 months. And I think while people are on the a female on that medication, they can't fall pregnant. And I would say the same with the male. They must do what they must do, and then washout period of at least 6 to 8 weeks before they start trying for a family.
Okay, that's good advice. Thanks so much. I think that's actually something that we were talking at a ward round the other day at Scare about how people falling pregnant, because these are new drugs, and we're still trying to understand the impacts on various things, like also, we didn't know that when patients go to theatre, they need at least 24 hours of being milk per mouth if they're on GLP-1s. Did you know that, Pete?
Yes, I did actually. It is because of the effect
important.
of gastric emptying.
Yeah,
It
very
delays.
important. And,
it's a
we
gastric
cancelled
emptying.
cases before for that reason. So, it's something that we need to be aware of.
Here's another question, Steve.
Oh, yes.
The question is, what does vaping do to the quality of sperm? Do you know that, or do we just have a generic, you shouldn't vape? It's like, as I said,
you mustn't vape. It's toxic. It affects the DNA. It affects the DNA fragmentation. So it's the same as with smoking. That's the short answer.
Okay, thank you.
Okay, good. All right. No, well, that's wonderful. I mean, Thinus, these two talks have been amazing. We don't talk enough or really ever about male fertility.
Well, that's why we've had such a clamor of people to say, when are we talking about it?
Yeah, and I think it's something that we need to know. The gynecologists, if anyone, would be the first port of call for these patients. And we focus so much on the women. And we just say to the guys, go and have a test, hoping for the best. And then when it comes back, we don't know what to say to them. And,
it's something that, semen analysis and things is something we've swept under the carpet. And I'm glad that we've actually magnifying this and bringing it into the light so we can actually address this and be more knowledgeable and more informed with what we can tell our patients.
Yeah, but it's nice to see that there is actually a lot we can do. We was like, well, sorry, now we know where the real problem is, off you go. But I mean, absolutely things to do. So it's great. I mean, give the patient some hope about the problem.
It's been wonderful having you, Tim.
Thank you.
I'm looking for your next talk. Yes, of course.
Yeah, I just want to, I think you're touching on an important point, Stephen, and that is if you find abnormal analysis or you're unsure, we are, I think, all the fertility specialists, we are a call away. You can call, and like I do with bladder problems, I can call and find out. I think it's important that we don't send the male away with uncertainty, because sometimes they are tagged. Morphology is 2%, but he's smoking. What is the meaning? Or the morphology is 2%, but it was done at a general lab. So it's unreliable. And I think very easy. I will always be available if you want to just touch base and reflect. You don't need to refer. It is just a discussion, and you know what to do or to say.
That's wonderful. It's a wonderful resource, Dennis. Thank you so much.
Great. Yeah. Thanks so much.
Thank you. It's been a honor to be part of your very active group. So thank you for inviting me. And I am available. I love lecturing. So I'm available if you ever need me.
Thank you so much.
Well, we certainly will have you back.
We certainly will. I mean, there's a lot of clamor to your talks.
Yeah.
And the great popularity is testament to how people find these useful. And I'd just like to thank those people that have been with us. And everybody here does say thanks. We've had people that say thank you very much for a wonderful talk. Looking forward to seeing everybody at SASOG next week. And then in 2 weeks' time, same place. And God willing, stay safe. And all the very best. And thanks, of course, to Chris, our indefatigable cage fighting technician. And we'll see you all again. Thank you very much.
Thank you very much. Right. Bye-bye.
Thank you. Goodbye.
Thanks, Thinus. Bye, Thinus.
Bye.